Hi there, I am Dr. Ajay Arora, and today we'll be discussing some of the tips in the management of diabetic macular edema. These are all case-based and hence very practical knowledge. So as I grew up in 90s and 2000, we were diagnosing diabetic macular edema as a clinically significant diabetic macular edema. And for that, we needed to have a retinal thickening, which you can see here. We had to have a retinal thickening which was within 500 microns of the centers of the macula. Or we had to have hard exudates, which were 500 microns of within the 500 microns of the macular center and associated with thickening of the retina, and a retinal thickening at least one disc area in extent, a part of which should be within one disc diameter of the macular center area. But this definition to a major extent changed with the advent of vocity and the classification put forth by drci.net. And this has simplified how we label diabetic macular edema. So when the diabetic macular edema involves the central 1 millimeter of the subfield of OCT, we call it a center involving diabetic macular edema. And when the center of the foveal center is not involved, then we call it as the non-center involving diabetic macular edema, or we even label it as an extrafoveal diabetic macular edema. Why is this important? It is important because for the center involving diabetic macular edema, like in this case, we require pharmacotherapy, which means anti-VEGF injections. But for the patient who has an extrafoveal focal diabetic macular edema that does not involve the center, the treatment is by focal laser, which means that if you do a focal laser here, you can avoid repeated injections of anti-VEGF, and this differentiation hence become very important. Now, let's look at some of the facts which angiography helps us in diabetic macular edema. Now, if we do an angiogram, and this is an angiogram of a time when we did not have OCT, and this picture I remember was taken way back in 2004, which is almost about 19 years back. It's a beautiful picture. And this patient came to us with a reduction of visual acuity. And the way to explain it was that the foveal avascular zone was enlarged, and the foveal capillary arcade, you see here the foveal capillary arcade, if I start drawing it, I can see that it was broken. So how do I measure foveal avascular zone? We have scale available in the angiography system, or you can look at the disc size, and if the disc is 1500 micron, or you can look at the size of the vessel. So if you look at the disc size, which is about 1500 micron, and this foveal avascular zone is almost as much as that. A normal FAC is about 500 micron, but if it exceeds 750 micron, we say that foveal avascular zone has got enlarged. We also look at the broken foveal capillary arcade. So this explains to us that there's something going wrong in the fovea, and that can explain as a drop in visual acuity. Now, certainly we do an OCT in these cases, and that would further explain to us if there is an ischemia and there is a foveal thinning. Now, let's look at a patient presents to you with hemorrhages like this, and we do an angiogram. The angiogram shows us an area in the foveal avascular zone that being enlarged, being irregular, and large areas of capillary non-perfusion, venous bleeding. So all this indicates that there is a significant amount of ischemia going on. So this patient, if OCT shows us macular edema in addition, then we give anti-VEGF and we do a scatter laser. But without doing an angiogram, we won't be able to reach this point. So a good metabolic control followed by a scatter laser. Now, this was a 64 years old male diabetic for past 15 years. You see here, there's a diabetic macular edema which is involving the center. There are hard exudates present. Patient is on oral hypoglycemics. The visual acuity is 6/24. And we find, okay, we should treat it with an anti-VEGF if the OCT shows macular edema. But wait, if we do an angiography, you see the angiography has been done and we have neovascularization NVE, we have NVD. So this changes the entire paradigm when we have to inject anti-VEGF and we have to do a pan-retinal photocoagulation. So such a patient would qualify for OCT, measurement of the macular thickness, a good metabolic control, would receive anti-VEGFs, and a PRP would be required. So fluorescent angiography helps us in identifying macular ischemia, identifying areas of capillary non-perfusion, pinpoints the leaking microaneurysms, and this is particularly useful in cases of a focal macular edema, which is extrafoveal, which will help us to target these leaking microaneurysms with laser photocoagulation, identifying areas of NVD and NV in doubtful cases, as the case I just showed you. And I feel that it should be done in all diabetics when you see them for the first time, even if OCT might seem to be a more useful technique, and we routinely do it in the clinic with the OCT. Now, what is the role of OCT in diabetic retinopathy? I think a lot has been talked about OCT, and we know that OCT gives us a histological picture of the retina without even touching the retina. So we can have a sponge-like edema, we can have cystoid macular edema, we can identify the taut posterior hyaloid, but the most important differentiation, which OCT helps us to get, is to differentiate a tractional versus a non-tractional diabetic macular edema. So like this is the case of a spongy and a cystoid edema, you treat it with anti-VEGF. But if you treat this patient, which has got a tractional macular edema, just with an anti-VEGF, it's not going to work like it happened in this particular case, who underwent multiple anti-VEGF injections till OCT was done, when we identified that this patient had a tractional diabetic macular edema. And once a vitrectomy was done, traction was released, the patient's macular edema came down. So this patient, one could have easily avoided anti-VEGF injections just by doing an OCT and identifying that there was a traction involved in causing macular edema. Now, there are situations where OCT tells us that there could be an inflammatory factor as an underlying process which is going on in diabetic macular edema. So these are some of the biomarkers which are relevant for finding out that steroids are going to work in diabetic macular edema. You have hyperfluorescence, which is diffuse. You have a foveal hyperautofluorescence. Then you have, the most important is this hyperreflective spots, which I'll just show you. And then you have cystoid spaces, a neurosensitive detachment, and increased thickness of the inner retina. Like in this particular case, you have a neurosensitive detachment here. You have increased thickness of the macula. You have these cystoid spaces, and you have these, you see these whitish spots, which are small, which are less than 30 micron, and which do not cast a shadow behind them. So these are hyperreflective dots or spots, and they indicate that such a patient would respond to an intravitreal steroids or a suprachoroidal steroid injections. Now, metabolic control in diabetic macular edema is extremely important. Like in this particular case, was a 57-year-old male, best corrected visual acuity of 6/12, left eye 6/24. OCT shows a spongy and a cystoid macular edema. What should we do? So this patient, ideally, we should have said, okay, let's do a metabolic control. and let's give an anti-VEGF injections like an Avastin or anti-VEGFs, and let's go ahead and see if we can do a laser photocoagulation like a grid. That was many years back when we got this patient. Now, this patient said, no, I don't want any injections. He went on to control his diabetes well, got a good metabolic control, did yoga, and came back more than 6 months later. And wow, the macular picture had changed. The macular edema had reduced significantly. The hard exudates come down both in the right eye and in the left eye, just to show you that it is extremely important to get a good metabolic control in every diabetic patient. Whether you're going to operate that patient or you're going to treat them with an anti-VEGF, the metabolic control is very, very important. This particular patient presented to me first in a multi-specialty hospital while I was at Max. So this is a 48 years old type 1 diabetic for 12 years, never referred to an ophthalmologist till admitted for dialysis. When the patient came to us, patient had this edema, neurosensory detachment. Patient was treated with dialysis. The serous detachment settled down, and the patient responded by a just good metabolic control, no anti-VEGF injections. Now, it's very important to control anemia in cases of diabetic macular edema. So this patient had come to us who had persistent diabetic macular edema, had received multiple injections of anti-VEGFs, Avastin, and this is many years back. And when she came to us, we knew that we are treating a patient whose hemoglobin was low, would never rise beyond 9.6 because she was a thalassaemic patient. But well, we decided to give intravitreal injection Lucentis. Patient received injections in both the eyes, but the macular edema did not respond. I consulted the physician and he said, sorry, the hemoglobin is not going to go up because she's thalassaemic. So in such a situation, it is important to increase the oxygenation of the macular area. And this is way back in 2009 when I went ahead and operated this patient, did a vitrectomy. There was no traction, but the main aim of vitrectomy was to increase oxygenation of the macular area, and that really helped the patient because patient's hemoglobin did not improve. Patient's macular edema came down, like you see in this case. The macular edema had reduced almost by 219 microns. The same thing happened in the other eye. Patient's visual acuity improved and patient did well. And I followed that patient up for almost 13 years. Patient did not require multiple injections of anti-VEGFs. And a vitrectomy in such a situation helped because the patient was thalassaemic and we were able to maintain good oxygenation of the macula post vitrectomy because that helps in oxygenation of the macular area. Now, this is a 33 years old female, and I want to, by this case, I want to drive home a particular point, which you'll realize in the end. She is a 33-year-old type 1 diabetic. For 17 years, she had blurred vision in both eyes. OCT was done, and you can see here macular edema in both the eyes, the right and the left eye. And this is the angiogram, and this is the metabolic features of the patient. There was no microalbuminuria, if you notice here. Patient's creatinine was good, so the kidney functions were good. And there was the LDL was on the higher side, but that doesn't explain the macular edema as such. So we had the option of giving an anti-VEGF injections, and of course, metabolic control had to be done. So patient, this is at that time we had injected injection Avastin. So this is 1 day post Avastin. Patient's visual acuity, which was very dramatic. Patient's visual acuity improved, and patient said that she was feeling fine. So what about the left eye? The left eye, the options were that we could have injected the same day, but we never inject Avastin or anti-VEGF the same day. We could certainly inject after 1 week, and that is what we had planned. Or we could do it much later, or we may not inject Avastin at all. Now, why we decided not to inject any anti-VEGF at all? Because when we did an angiogram of the other eye, 1 day after we had injected in the right eye, there was a bilateral resolution of fluid. So please remember, this is an unusual presentation, but if the patient says, look, injection in one eye has benefited me in the other eye also, please have a look at the other eye, because you may not need an injection in the other eye because uh, this is rare, but there's an explanation for that one eye injection can help rarely macular edema in the other eye. Now let's look at the role of laser. Now, as I said earlier, if you have a patient with an edema which is located away from the center and the center is okay, one could go ahead and do a focal laser to the leaking macular aneurysms. And this is a sequential follow-up of a patient over the period of 9 months of how the hard exudates gradually uh, disappeared after lasering the leaking macular aneurysms. No anti-VEGF injections were required and the patient did well. Then there are situations where sometimes we may not want to intervene. Like this is a patient who came to me in 2013 with a visual acuity of 6/6. Patient was phakic, type 2 diabetic for 12 years. This is the HbA1c. So if a patient had a visual acuity of 6/6, but had some cystoid spaces. So for me, the option was systemic control. Yes, we should do the systemic control. The question was, should I go ahead and do something for this by injecting an anti-VEGF or a steroid or a micropulse laser? But I decided that we should not intervene. We decided to follow up this patient, and 2 years later, so for 2 years, patient did not need anything. The patient's visual acuity dropped after 2 years, came down to 6/9, and this is post-Lucentis, and patient had come back to the state where the patient was 2 years back. Visual acuity had regained to 6/6. So such situations is important sometimes to closely follow up the patient. Other situation, like this is a one-eyed patient where the macula was good. There is a traction which is present nasal to the disc. It is not causing any problem with the macula. It is unlikely to cause a tractional retinal detachment, and the patient is one eye. Please leave it. Do not intervene. Just do a close follow-up. This is another patient who has had laser, who has a large ischemic macula with a foveal avascular zone which is enlarged and irregular. So such patients, there is no point doing a laser photocoagulation in areas where of leaking microaneurysms or areas of the capillary non-perfusion areas. It is best to leave them alone. There is no need to do anything. Now, we get patients of macular edema with cataract. What should we do? If you have a patient who has mature cataract, one could go ahead and inject an anti-VEGF, and then you go ahead and operate this patient, put a single stitch so that you are able to intervene as soon as possible after cataract surgery when the media clarity occurs, and you're able to treat because you've never been able to see the macula before. And now when you're able to see the macula, then you can take an appropriate decision. But if you can see the macular area and you do not treat it and you go ahead with the cataract surgery, like it happened in this particular case, this is what would happen. This patient came back with multiple retinal hemorrhages and macular edema, which was cystoid in nature. This becomes a medico-legal case. It's very important that this patient had normal lipid profile, had never been lasered, and according to the patient, the fundus had not been evaluated before. But it's important that, so it's the learning from this case is that please have a look at the macula. In case there is macular edema, treat it, wait for about 10 to 12 weeks before you go ahead and do cataract surgery. If cataract surgery is mandatory, if it is a uniocular patient who cannot function without the cataract being out, you can give an anti-VEGF, tell the patient that macular edema may worsen, put in a stitch, do the cataract surgery, and have it evaluated by a retina colleague so that intervention can be done as soon as possible, maybe within a few days after cataract surgery. It's medically important to do this. So, the take home for the patients with cataract and DME is detected in the other eye with a mature senile cataract, as I said earlier, intravitreal anti-VEGF followed by phaco with a single stitch, and then you do needful as per the case, as per the diabetic macular edema suggests the treatment. Now, DMA with a minimal cataract, treat as per protocol and do phaco about 10 to 12 weeks later. DMA with vitreous hemorrhage or TRD with a cataract, you should give an intravitreal injection of anti-VEGF. We normally wait for about 3 or 4 days, and then we do a combined surgery or a phaco with a vitrectomy. So the take-home message, friends, is differentiate between a center involving diabetic macular edema and a non-center involving diabetic macular edema. Use FFA and OCT judiciously. It will definitely help you in treatment. A good metabolic control is a must. You must include anemia control. Anti-VEGF injection is the treatment of choice for center involving diabetic macular edema, and focal laser for an extra focal edema. If inflammatory OCT biomarkers are present, then you must consider steroid treatment. In case there is a traction of diabetic macular edema, then a pars plana vitrectomy should be done. Control of diabetic macular edema is a must before cataract surgery, or if you cannot do it yourself, please take help of your retina colleague. Thank you for your kind attention.